This is the perfusion review for care of the patient with chronic conditions. I've pulled up the review that's posted in Blackboard, and the first thing on that review is be able to place a 5 lead. So this is our copies and pastes of the pictures that were in the assignment that you submitted through Blackboard. So on your exam, it'll look like this, and you'll have hotspot questions like, where do I place the brown lead? And you would click. Where do I place the green lead? And I would click. So start white on the right, and then the way I remember is either clouds over grass or snow over grass, and then smoke over fire for the left, and then the last one left is the brown one, or poop comes from the tummy. So again, this question will have an image like this one, and it'd be all, where would the nurse place the brown lead? And you would click on where you would place that lead. Be able to identify the cardiac rhythms from the cardiac rhythm sheet given out in class. This sheet is also available in Blackboard. So I'm going to stop sharing this screen and share the PDF that was posted in Blackboard. So you guys used this PDF document to identify the rhythms that you turned into Blackboard. So let's look at this a little bit. So we have our normal sinus rhythm, and how do we know it's normal sinus rhythm? So for every P, we have a QRST, and they're evenly spaced, and you have a rate of 60 to 99. Counting and multiplying by 10 will give you an estimate of what your heart rate is. The actual counting of the small boxes will give you a more accurate heart rate, and you guys will learn that in health and illness in level 4. So an estimate on this one would be 1, 2, 3, 4, 5, 6, 7, 8. So an estimate would be 80, and when they do the more accurate one, it was 71. But it still gave me a good quick view, like, hey, this is normal. This is between that 60 and 99. Our sinus tach here, this one was a ventricular rate of 125, but we could see it's much faster, but we also can see that it's pretty normal, or not normal, but it's uniform in its appearance. Like for every P, there's a QRST, and that they're evenly spaced, and they have that 1-to-1 ratio. So our sinus tachycardia, when we're looking at this, like if you're exercising, you notice that your heart rate goes up. You're going to have a sinus tachycardia. Excitement, anxiety, all can make your heart rate go faster. So there's other things, like if we have pain can cause an elevated heart rate, respiratory distress, hypoxia, dehydration, hypovolemia, hypotension, fever, infection. I suppose fear could also like an emotional response, but the ones I was looking at was fever and infection, septic shock, pulmonary embolism, anemia, hyperthyroidism, and hemorrhage. If we have something that's not like exercise or exertion causing the elevated heart rate or the sinus tachycardia, we do want to treat it. If the person's having anxiety, we'll give them an analytic. If this sinus tachycardia is occurring because that person has an infection and has a fever, we're going to give antipyretics as ordered, and we're going to give our antibiotics as ordered. If the sinus tachycardia is coming from like hypovolemia, whether it's coming from hemorrhage or diarrhea and vomiting, we're going to give fluids as ordered. If it's coming from hemorrhage, we stop the bleeding, and we may give blood as ordered. Our sinus bradycardia, overall, you have that 1-to-1 where you have a P for every QRS. The rhythm and the atrial and ventricular rhythm are both normal. Well, regular, but it's slow. This one is a rate of 48 a minute. So sinus bradycardia, we know like it can be normal and an expected response in athletes and during sleep. So if I have somebody who's young and athletic and they come in and I'm the nurse taking their vital signs and their heart rate is really slow, I'm not going to think it's something bad unless it's coming with other symptoms, like if they're pale or lightheaded. Conditions such as vagal stimulation, increased parasympathetic stimulation, and decreased sympathetic stimulation. Non-cardiac hypothermia, hyperkalemia, hypothyroidism, glaucoma, and increased intracranial pressure can all cause bradycardia. If the person's asymptomatic, we only observe. There's not necessarily treatment needed. And if they are symptomatic, we will give them oxygen, atropine, transsubcutaneous pacing, consider sedation and analgesia, and dopamine to raise the blood pressure. If it's symptomatic. If it's asymptomatic, we are just watching. With any type of dysrhythmia, the nurse should monitor serum electrolyte levels because electrolyte imbalances affect cardiac depolarization and repolarization. So again, with any type of dysrhythmia, the nurse wants to monitor electrolytes. So we have our atrial fibrillation. That P wave isn't really discernible. It's just kind of like flopping around with fibrillation. That P wave is like flopping around. And we have that QRS. So this rhythm is atrial fibrillation. Atrial flutter. So we have that really distinct sawtooth pattern with atrial flutter. With atrial flutter, like the patient might be like, I kind of feel palpitations sometimes, but other than that, it's not really bothering me. In that situation, they still need to be seen by a medical provider, even if they have no other symptoms besides that occasional palpitation. So main things with atrial flutter is that very distinct sawtooth pattern. And even if the patient only symptom is that palpitation, they still need to be seen by a medical provider. So we have ventricular tachycardia. We have that tombstone pattern. This can be caused by low potassium, low magnesium. And this is defibrillation only if pulseless. Ultrasounds de points, or that twisting of the points, like it's a form of ventricular tachycardia when you see that really wide QRS, and you kind of see it like going up and down, up and down, up and down. Like it's like a twisting of the points. It's a polymorphic V-tach, and the main cause of this is it's usually caused by low magnesium. So the nurse should anticipate to give magnesium sulfate. And if it's pulseless, you will defibrillate immediately. Ventricular fibrillation, that's going to be our immediate defibrillation. So if you want to highlight that or asterisk that on your sheet. And our ventricular fibrillation most commonly leads to sudden cardiac death. And I don't see that on your notes, so if you want to write that in on your sheet, our ventricular fibrillation most commonly leads to sudden cardiac death. Asystole, there's no P waves, no QRS complex, there's nothing going on. This is a lethal rhythm. We do not shock because there is no electrical activity of the heart. This one will be like immediate CPR and atropine and epinephrine. So I'm going to stop sharing that sheet and go back to our Word document that's the review. So we did mention that ventricular fibrillation requires immediate defibrillation. Lifestyles for healthy cardiovascular disease. So that's going to be getting plenty of exercise, eating well, diet low in fat, not smoking, limiting alcohol use. So metoprolol is a beta blocker. So it's blocking the sympathetic nervous system, both cardiovascular and lungs to some extent. So that being said, it's our beta blocker, it's the 2. So we avoid patients that have like COPD or asthma or any kind of respiratory illness. Metoprolol, we probably remember it from our hypertension drugs from pharmacology, but this drug also treats cardiomyopathy and cardiac dysrhythmias. The electrical pathway of the heart. This was taken from one of the videos that we watched in class. So our electrical conductivity of the heart starts at the SA node, moves down to the AV node, goes through the bundle of His, and then disperses through the Purkinje fibers. A normal heartbeat originating at the SA node should be 60 to 100 beats per minute. If the SA node is not functioning, the backup pacemaker, the AV node, will take over, but that beat will only be between 40 and 60. If that is not working, you might have some conductivity at the Purkinje fibers, but take note that that's only 20 to 40. So our warfarin and our enoxaparin, I'm kind of going over those together. So our warfarin, it's a PO pill. It prolongs clotting time. We're giving that to people that we don't want to have clots. So whether it's like a mechanical heart valve, atrial fibrillation, something that we don't want them to have clots. And then enoxaparin, we're also giving for clots. Sometimes it's giving prophylactically for patients that are on bed rest in the hospital. For people who we don't want them to clot, it can create a bridge. So important things to remember about this is warfarin requires a PT-INR. Vitamin K is its antidote. And it can take up to 2 to 3 days to start to reach therapeutic range. And it takes time to get out of your system. Enoxaparin has like that 12-hour window where it's therapeutic almost immediately, and it lasts that 12 hours. So if I stop somebody on the Coumadin, I have to stop them like a week before a surgery. So they're going to have that week where they're not fully protected from clots. So when you stop the warfarin, you could start to give them the enoxaparin. So they'll have to take it every 12 hours, but then you can quit 12 hours before surgery or 24 hours before surgery, and you have a window of only 24 hours versus 1 week where that patient isn't fully covered or protected from clots. So those are the things to think about with warfarin and enoxaparin, that because they have different periods of time where they reach their therapeutic level and different periods of time that it takes for them to get out of your whole system, you can use them as a bridging therapy to decrease the amount of time that somebody is without protection from clots. AFib, causes, symptoms, and treatments. So atrial fibrillation, basically the atria are quivering instead of beating effectively. When the atria are quivering, they allow for blood to kind of stay still in those atria, kind of like stagnant or like a stasis of that blood. So when you're thinking of stagnant or stasis blood, it's just kind of sitting there, it's pooling there, and that gives it the potential to clot. And then when those atria do contract and give an effective beat, they're going to throw that clot into circulation. So with AFib, if we can use like an antidysrhythmic, like amiodarone or something to get them out of AFib, that's good, because then we can get them out of AFib, or like a cardioversion to get them out of AFib. If we cannot correct or restore that AFib to some type of sinus rhythm, or some type of other rhythm that's not the quivering of that atria, they're going to have to be anticoagulated. They're probably going to be on warfarin, just because the atria are quivering, and that's blood that's not moving, or that stasis of the blood is causing a potential for clots. So, okay, one, we want to try to correct that rhythm. If we can't correct it and that atria is going to remain in this state where they're quivering and have a high risk for clots, we want to give the patient an anticoagulant to decrease the chance that they're going to create a clot and then throw that clot into circulation, and then it lands up causing a stroke or pulmonary embolism or a DVT. So if we can't correct the rhythm, we're going to give anticoagulants. So all of these, the Trousseau's de points, we noted that magnesium is probably our biggest cause of that. And then our A flutter, asystole, ventricular fibrillation, ventricular tachycardia, sinus tachycardia, and sinus bradycardia. Just make sure to be able to identify those. Go back and look at that PDF document with the cardiac rhythms and go through, read it. That's all I have to go over on this sheet. Maybe I'll hit a couple of things on your concepts of perfusion. Well, let's see. I'm going to stop sharing. And so this is your concepts of perfusion worksheet that you turned in through Blackboard. I'm just going to go over a few things on it. So relate the influence of the autonomic nervous system on the heart. So the autonomic nervous system is comprised of the sympathetic and the parasympathetic nervous system. So we know the sympathetic nervous system is going to increase heart rate, and parasympathetic is going to slow it down. The components of the autonomic nervous system that affect the heart are the vagus nerve of the parasympathetic nervous system and the nervous fibers of the sympathetic nervous system. These fibers play a vital role in the rate, impulse formation, speed of conductivity, and the strength of the contraction. For example, vagus nerve stimulation causes a decreased rate of the SA node firing and slowing impulse conduction of the AV node, whereas the sympathetic nerve stimulation firing of the SA node increases AV node impulse conduction and increases cardiac contractility. So sympathetic is increasing it and the parasympathetic is decreasing it. Trace the normal conduction pathway of the heart. There was that image earlier in the recording from the YouTube video that we watched, but we're going from SA node to AV node, bundle of His to Purkinje fibers. In your own words, describe how dysrhythmias relate to the concept of perfusion. So if the heart electrical system isn't working appropriately, the atria aren't contracting when they need to or fully, and the ventricles aren't contracting fully or effectively. So when they're not contracting correctly, they're not going to give nice, good, full pumps of blood to the heart, and that's going to decrease perfusion. What would your priority nursing assessments include for a patient exhibiting a dysrhythmias? ABCs, monitoring through ECG, the presence of the waves, the segments, the heart rate, the heart rhythm, respirations, rate, rhythm, the effort of breathing, lung sounds, the patient's response to the rhythm. Like, are they symptomatic? Are they having anxiety? Are they dizzy? Are they sweating? Are they having pain? Oxygen perfusion, you're monitoring their O2 stat, the skin color, their skin temperature, and you're monitoring electrolyte imbalances. A systematic approach to evaluating a strip, we're looking for that P wave. Is it upright? Is it inverted? Is there one QRS for every P wave? Is there more than one QRS for every P wave? Do we have that 1-to-1 ratio from the P waves to the QRS complex? So our P wave, just to remember, our P wave is that atria contracting. Is there any atrial fibrillation or fluttering in those P waves that you can see? Is that atrial rhythm regular, irregular? Is the ventricular rate regular, irregular? And then as you guys progress more with strips, you'll get in more detail about measuring the lengths of the complexes. But for this up to this point, for these 9 strips, the main thing that we need to know is the P wave is the atria, the QRS complex is the ventricles contracting. So P, atria contracting, QRS, ventricles contracting. Is there one for each one, and is it regular? So synchronized versus unsynchronized cardio conversion. Synchronized, it's going to synchronize with the R on the QRS complex, and it's going to be 50 to 100 joules. In unsynchronized, the shocks are greater at 120 to 200 joules, and they fall random on the cardiac cycle. What is the significance of anticoagulation for the patient with atrial fibrillation? So atrial fibrillation puts patients at an increased risk for thrombus formation due to blood stasis. If the patient is in atrial fibrillation longer than 48 hours, then anticoagulation therapy of warfarin is needed for 3 to 4 weeks before cardioversion. And they do this because the cardioversion has the potential to dislodge a clot. However, if the transesophageal echocardiogram performs and there's no clots present, anticoagulation therapy may not be necessary. Also, if drugs or cardioversion does not convert atrial fibrillation to normal sinus rhythm, then long-term anticoagulation therapy, usually with warfarin, is needed to prevent clots from forming. On our antidysrhythmics, the only one that I'm requiring you to know for this test is metoprolol. It's a beta blocker. We're using it to treat dysrhythmias, general myocardial depressant for both supraventricular and ventricular dysrhythmias, and cardiomyopathy. And we learned it initially too for treating blood pressure. So hypertension, dysrhythmias, cardiomyopathy. And that's everything that I have on this sheet. The case study, I'm looking through that, and it asks you again how atrial fibrillation differs from normal heart rhythm. We talked about that on the review and on this sheet a little bit. It's just with atrial fibrillation, the atria are kind of quivering, and they're kind of static, and this quivering it allows blood to pool and potentially create clots. We use warfarin to treat atrial fibrillation so that they don't form clots, or we reduce the chances of them forming clots. Something that's not on your sheet that you should know is our INR levels. Let me stop sharing this and go back to your other sheet. So INR level. So for let's see. Okay, so our INR levels when using warfarin or Coumadin for clot prophylaxis, for DVTs, our level should be 1.5 to 2, for AFib 2 to 3, and a mechanical valve 2.5 to 3.5. So when we're looking at this and you see somebody with like an INR level of like 7.9, we know that that's a critical level. We're not going to give any anticoagulants. We would give any vitamin K that's ordered, and we might be anticipating to have to give fresh frozen plasma if we have somebody with a critically high INR level. So to know what our critical high levels are, or know that, hey, this INR level is like really high, just take a look at what our therapeutic ranges are for our INR levels. Anytime a patient is going to start a new drug, when they're taking warfarin or Coumadin or any other drug, they need to let their primary care provider know, just to make sure that there's not going to be any interactions. So does this only pertain to over-the-counter drugs? Like in our case study, we had the proton pump inhibitor perpetuating the effects of the warfarin. So this doesn't only include over-the-counter drugs. Like even our like our CAM therapy drugs, like if they were going to start taking garlic or ginkgo, or any other drugs that might prolong bleeding time. What are our signs and symptoms of bleeding? So we could have our patients that are bruising easily, those black tarry stools, new onset of dizziness, pain, joint pain, unexplained abdominal pain. And as we look at our case study progress, go back and review bridging therapy. And I think that's everything that I have for this review. I will try to get it posted as soon as possible. It should be posted soon. If you watch this and you have any questions, please email me and let me know if you have any questions.